Hello, good afternoon, ladies and gentlemen, and welcome to those of you here in the room and also those online to this fantastic panel discussion on harnessing the European data space, challenges and opportunities in a fragmenting world. I'm Naomi Lee from the Ellison Institute of Technology in Oxford, and I'm absolutely delighted to be joined on stage by a fantastic panel. Before we get into the discussion, I wanted to give you a couple of highlights of the European health data space to orient the discussion. This topic is pretty personal for me because I feel like I've followed the inception of the European health data space from afar, from what was an initial idea to something which is really living and breathing. And we were getting excited together as a panel just before coming on stage of this idea of this is really health policy that's gone from an idea to something that's really now coming into action. So my involvement with the project began 5 years ago when the German Federal Ministry of Health and the DG Sante from the European Commission asked me to moderate a discussion 5 years ago, mid-pandemic. So I feel like I was the only person in Berlin and everybody else was online. I hope many of you were either online or in the room, which was ended up with the Berlin Charter, which was almost one of the founding documentations of the European health data space. And I remember thinking at the time, wow, fantastic event. Here we are in Berlin in the middle of the pandemic. This is completely surreal. And perhaps that contributed to this idea of is this real? Is this really something that could happen? The ambition of the project felt completely tangible. And yet here we are, almost 5 years later, with the European health data space adopted earlier this year, with the key aims to make a harmonized, secure, interoperable use of health data across the EU. I wanted to just reiterate the two primary aims of the European health data space for those of you who are coming into the topic, which has always been about balancing primary use, so supporting healthcare delivery at the point of care, giving individuals better access to their data, allowing cross-border care, with the benefits and the opportunities for secondary care, so enabling data reuse when it's anonymized for research, for public health and also for policy making. So this opportunity to do some personalized or targeted public health based on data. So we're in a position now where the regulation is enforced but not fully implemented. And I just wanted to give you a couple of key dates that might be useful as we go into the discussion, which is to say, member states are now working on, from a background of different degrees of readiness, for a couple of key dates. So in my mind, 2029, the target for the exchange of the first priority healthcare data categories for primary use. 2031, extensions to clinical trial data comes into use. 2034, possibly for international organizations and third countries to apply to join for secondary use, which I think if you zoom out from saying it's this is something that's gone from an idea to something which is fully ready to roll out in that time, it's a really, really remarkable project. So I'm really looking forward to getting into this with the panel and discussing the benefits, which are obviously huge, but also the potential challenges, which a project like this, I'm looking forward to exploring more. So let me welcome my panel. To my right, I have Dr. Thierry Pizzo, who I'm sorry, I'm having a technical... This is the thing, you should never have technology, even if you've come from a technology company that you're dependent on the stage. So Dr. Pizzo is the Chief Medical Innovation Officer at the North Estonia Medical Centre in Tallinn. But Dr. Pizzo, you've also spent time at the European Commission working on digital health, e-health, and aging. With us on stage is Aldo Faisal, who is a professor at two institutes, both the University of Beirut and Imperial College London, and working on machine learning, neuroscience, and biomedical engineering. Looking forward to hearing a lot more. We have Elizabeth Kesselingen, who is a distinguished leader in the European health advocacy community and currently CEO of the European Multiple Sclerosis Platform and Vice President of the European Patients Forum. We have Emily Passamard, who is an expert both in digital health and in law, which I think is an incredible intersection and so useful. So since 2019 has led on legal affairs for the Delegation for Digital Health at the French Ministry of Health and is responsible for working on the European health data space and working about how you assimilate the local and European level requirements, and a last-minute stand-in, Joe Leonard. So it's very sad that Marco Marcella unfortunately couldn't make it. He's come down with a high fever. It is that time of year. But Joe, thank you so much for joining us on stage. You are the Chief Scientific Officer at an AI startup, Boston Gene, which is working on personalized cancer care. And you are previously a Professor of Medicine at Harvard University. So welcome. Please wonder if you'll join me in welcoming the panel to the stage. Terry, I wonder if I can come to you first. In conceiving a project of this size and complexity in execution, it's super important that we understand what would be the benefits for clinicians at the point of care, and what do you see as the kind of incentives or challenges for clinicians in working towards the requirements of the European health data space? How real does that feel on the ground?
Thank you. Is it on? Yes, it seems like it's on. I really feel embarrassed that some people are with my back, but I can't turn constantly either. First of all, I'm very grateful for this opportunity, and I think that it's the fantastic vision of the organizers to have all of us on this panel, because it seems to me that sometimes we are very keen on listening to these political views and ideas and how it all should happen and what the framework should be around it. And that's all very necessary. But there is always somebody who has to do this real work. And that's the hospital. So I think that it's good for having also the view of these people who create most of the health data. Of course, it's not only the hospital. It's quite few of the health data that are actually created in the hospital compared to the data which are outside. The outpatient clinic, the GPs, your own public health well-being apps, all kind of information that concerns your health. A lot of this is outside, but we do daily. What we do in the hospital is collecting data. And I was also one of these commission officials who was at the starting of discussions around creating the health data space. And the idea was, of course, coming from the cross-border healthcare directive in one way, but also from the research requirements to generate, to give the possibility for the research, have an opportunity to have more than limited access to health data that we have in the EU. Because the biggest member state, Germany, is only 80 million. But if somebody is looking for 5 million diabetics, then they usually go somewhere else outside Europe. So I think that it's a good, very valuable and very useful tool. What we look from this as a hospital is, of course, that it would be a booster for improving the data quality, the standards, to make them more handy for the primary or secondary use, but also for our own quality control, which sometimes is difficult because of these different data collection ways and formats and standards and a lot of free text in it. And that is quite demanding exercise, but it's a good booster. So I think that is one of the values. I would say that as I come from Estonia, and Estonia has already for quite many years in place the health information system, which is nationwide. So all our patient data are in one place and accessible for the primary use at any healthcare provider's service. So that is not for so much new for us. And we have also quite good exchange, for example, of e-prescription with a number of member states. So that is not for us the primary benefit, but just the correction of data, making them in the standardized format, making them available for the secondary use. I think we as the hospital, which also does quite a lot of research, as well as for the patient safety, for the quality control, I think that's a good start.
Amazing. So you can see benefits really at the local level.
Absolutely. I would leave all the challenges for the next intervention.
Okay, I love that. Aldo, I wanted to ask you, so a lot of the work that you do must draw on other similar big data sets. And I wondered if I could ask you specifically, when you think about the European health data space, what's distinctive about it? What opportunities does something on that scale open up for you? And what do you think, particularly in the era of AI, what do we know now that we didn't know 5 years ago when this was coming to be a kind of project at inception?
Sure. So I've been for 20 years now in Britain, and at Imperial in Northwest London, we had some of the first large data sets, 2.3 million patients, all primary, all secondary data linked and available. So we've been able to pioneer things. And the UK has been about 5 to 10 years ahead than most of Europe in that. What this meant is that we could pioneer a lot of AI tools and technologies that we were developing and prototype them at the scale of 1 to 10 million people. But what we've all seen with the AI revolution is that AI systems really become smart once you're approaching data set sizes that, in the case of language, spans all English text on the internet, for example. That's how ChatGPT-3 really became somewhat smart. And what we have now is an opportunity to scale up the development of tools that we've prototyped that operate. So, for example, in the country of Wales, one of the 4 countries of the UK, we can now predict with over 80% accuracy for every single patient if they have a risk of critically deteriorating and being emergency admitted to hospital. That completely transforms how you're thinking about primary and pre-primary care, how you prioritize resources, how you interact with individual patients at the GP level. And so once you have these capabilities that you only really achieve once you're seeing millions of patients, you can start really thinking about building even smarter technologies. And so in the anticipation of the EHDS data coming online, that in this region of the world we'll have access to 500 million patients worth of records. So this is almost 1 trillion or more records will be available potentially. What transformative effect we can have on understanding health at a completely holistic level. And I don't mean it esoterically, I mean it really with deep scientific understanding. So in March this year, we launched Nightingale AI, which aim is nothing less than become the world's largest health foundation model. That it doesn't reason about language, like many other AI models related to health, but reasons about medical data itself. And so we already have as much compute pledged towards us as ChatGPT-3 had, and we have already 4 million patients worth of records that were pledged to us, and this model is just growing. And once you really operate at a planetary scale, we can deliver planetary intelligence that democratizes access and knowledge about healthcare for the whole world, I hope.
Wow, that's so exciting. And what I think you're describing here is the kind of intersection between research, but also using data at this scale almost as a kind of real-time dashboard for policymakers to make decisions about the healthcare system. Is that aligned with what you're describing?
Yeah, we have a fully integrated view of that. I mean, ultimately, we will have a digital twin of the NHS where we can trace and track every single patient's progression. Their doctors will know, the patients will know, policymakers, hospital operators will all know at these levels. And this is what's possible at a European scale level. And nothing in what we're doing is limited just to Europe, of course, but it's just the scale that we're achieving that will open up doors to other countries to join and participate in these type of infrastructures.
That's fantastic.
If I may just to interfere, I have heard these 14 years about the digital twin. So far I have only understood that we have a digital twin liver. Not more. When are we going to have the digital twin?
So for Wales, we have now a digital twin for every patient that is fed from operational data out of the NHS. It's not.
You use it?
As a research, now we need to work with the public health authorities how to make it available for them. And it's a question about what exactly your twin looks like, what we know about you and what we don't. And this is evolving now, yeah.
Elizabeth, let me ask you, so a project of this size and scale, it requires the public as a kind of civil society, but also patients, to have a really strong understanding of the project and what the benefits are. Could you talk to me, based on your experience, of what you would recommend here about the most important components of a communication strategy. You know, what do people need to know about this project?
Yeah, thank you for the question, and thank you for having us. I mean, European Patients Forum as a stakeholder here, as we believe as patients, it's very important. We see with the European health data space that what is coming up is more empowerment for the people to be more informed, but also to take the best decisions for their care, an informed decision. And what we see is that there is a need first to engage more with patients at a very basic digital skills level so that they understand what this means, what it is that we're talking about when we're talking about the European health data space, and how can they contribute. So building up that relationship and engagement towards the patient is important. Building the trust, because the data comes from the patients. And the patients needs to be able to trust the process and be compliant with sharing their data to ensure that all these, the dream actually comes true of the European health data space. And those challenges, that is building the trust with the patients, needs to be addressed at a very ground level to make sure that everyone is included. And what we see also in the data that is collected now is that there is a lack of certain patients or group of patients that are excluded. So how can we bring them on board at an early stage and help engage the patients in different processes at different times to make sure that they co-design all the processes and with all the stakeholders involved, be it in the hospitals, be it at policy level, with researcher, but the patients needs to be there, and for that they need to be educated. So what we did as the European Patients Forum to one of our initiatives called the Data Saves Lives, is create this toolkit that really gives us the principles of how to engage with the patients, build that trust, and what is needed. We also see that within this framework, we still don't see in practice how the patients are going to be engaged, but also how to build this public-private partnership to where are the funds, the resources to build all this. It's not clear, so it would be nice to have some clarity on this from the Commission or from the Member States who is going to invest in those processes, and to make sure that the patients are engaged at all levels. So there is a lot of questions in practice how this is going to work out.
Data Saves Lives was such a fantastically impactful campaign. What do you think were the kind of key components in that you could call out?
So there is a call for the policy decision makers and also for the Commission to really include the patients and make sure that there is co-designing in place in the different framework that we are building together. There is also some tips on how to build this trust and relation with the patients and how to engage with them. But most importantly, there is also a clear description on how the patients' organization can be involved, what's their role, so that all stakeholders can understand. Sometimes it's not very clear, we're talking about patients' organizations, but what do they know? They're patients after all. That's what we would hear. And we can see the skepticism when we are around the table. But as a partner, we have to be seen, and the patients' organization have to be seen as equal partners in the process. And I think the Data Saves Lives really give that multi-stakeholder approach and help build that confidence to build and work together.
I just have to interfere here also because I have a pleasure of being in the advisory board for Data Saves Lives. And I see the biggest benefit of it is in the title of it. That data saves lives, because this is so easy to hide behind the GDPR and forget the value that the health data is a public good, because that brings benefit for everybody. If not for you, then maybe your children or your family or population in general. So that people understanding that this data sharing and access to health data is a good thing to do. I think that is how this title was selected so brilliantly.
I couldn't agree more. And I think there is a lot of education to be done towards the patient on that topic. As I said, building trust. Data is not about, because we have this image of like our data is used, but we don't want it to be used. but yes, we want it to be used at the end of the day for the research, is to make sure that we work on your conditions and we find solutions. But they need to understand that, and everyone needs to understand that. So I think thank you for reminding us, but indeed, data saves life.
Yeah. So we need to come up with another very lovely tagline for the European health data space saves lives too. Oh, fantastic. Okay, Emily, please could you tell us, as a member state, how are you preparing? And you must also be thinking a lot about the elements that underpin trust and how you kind of embed that within your preparation.
Thank you, Naomi. Thank you for being there. Very happy to. For France concern, I think there are maybe two main words to keep in mind if you want to succeed in implementing the EHDS regulation. It's trust. I really join you on that point, and consultation. And that's precisely why we chose at the French Ministry of Health to involve as early as possible every stakeholder involved in digital health in the preparation of this regulation. We started first, of course, in 2022 with the proposition of the European Commission, and we made a public consultation at this moment, and we are doing this consultation in order to have real feedback from the field and to imagine. Sorry, I think it's not working. Thank you. Yes, it is. Okay.
If you've got another mic, that would be amazing. And
okay.
Timekeeping device.
This is a message for me, maybe. I have to be...
No, it's that I realized I haven't got my watch on, so I'm...
Okay. And to be very concrete on the EHDS regulation, what we've made in order to prepare our ecosystem to the arrival, we identified 15 topics that we believe are really important and really crucial for implementing EHDS regulation. And we made some 15 sheets that we put into public consultation on several topics, as I said. And we received around 200 contributions from very various stakeholders, patients association, of course, hospitals, searchers, health tech companies. And after that, we started and launched several thematic working groups that are still working at the moment we speak, trying to go further into specific topics like, for example, how to implement opt-out rights for secondary use for people. What can be the relationship with between the HDAB, health data access bodies, that has to be designated at national level, and trusted data holders, for example, because in France we will have some trusted data holders. And other topic concern, for example, security requirements that we found important to put to ensure European health data sovereignty in a certain way. These are 3 examples of the topics that we work on at the moment, and all of this work contributes also to our national AI and health data strategy ongoing at the French level. This is for all the stakeholders involved in the e-health sector, and we also had a specific method to reach out to citizens, which are not always patient, but maybe one day they will be. And so we organized last year a citizens committee making 30 citizens work over 3 weekends and asking them to answer this question: when implementing EHDS regulation into French law, what rules and specific safeguards do we need to provide to ensure proper use of electronic health data while fostering public trust? And they made more than 50 recommendations, very very interesting ones related to that we could, grouped into 4 main categories: data sovereignty, security, transparency and information. We talk about digital literacy here, and also eco-responsibility that we sometimes forget. And with all this material and inputs, we are now at national level drafting a national law to implement EHDS regulation, because we need it, and each one of the 27 member states will need it. So it's quite challenging because the date that you evoke, the roadmap, it's quite short. And we also use this work to negotiate all the implementing acts that are now on the board of the European Commission, and we are negotiating those very concrete decisions that are going to apply in each one of our 27 member states. So still a lot to do.
I'm really curious, in the kind of panel of citizens that you assembled, when you began the discussion, what was the level of awareness about the European health data space?
Zero. Zero at the beginning of the first weekend, but we launched several experts to train them, and what we were really very astonished to see how the high level of interest that this topic raised among the citizens, and this was really extraordinary and a real big commitment from them to make some recommendations that I've found, for example, as an expert, really incredible, and lots of recommendations that we've never think about it. Specifically, for example, for eco-responsibility topics. It was really surprising for us and really inspiring.
It's
truly.
Absolutely fantastic. What a great initiative.
Thank you.
Joe, firstly, thank you so much for stepping into the breach. It's absolutely fantastic to have you join the panel. And it gives us the opportunity to ask from outside of the European perspective. And obviously, you're in an incredible position where you have a foot within Europe and a foot within the US. And so you're able to give us both the kind of inside and outside view. But from the US perspective, what do you think of the European health data space? Like, what do you think it gives Europe in an increasingly fragmenting world?
Thank you very much for having me. That's a very good question that reminds me of the title of this session. I don't know if you looked at that. I think the fragmentation of the European sector or market is certainly one of the dominant features for Europe as a market. The commercial potential, or for a startup to enter the European market, usually happens in 1 or 2 countries, maybe 3. But to have a commercial strategy across all the different member states is hugely challenging and requires tremendous resources. So I think it's important to reflect on that. The second part is that in the current, let's call it rising world of data availability, I think the governance framework of the EHDS is anticipatory. We don't even know what will happen over the next 10 years. If someone reflects back now, what we planned 10 years ago, there was no GPT infrastructure, there was no diffusion model, there was no generative AI. So in a way, we have to also recognize that this is the prospective potential that we're governing right now. So both things together make the European market more attractive. If there's a unified, let's call it harmonized data space, and we're talking about a virtual space. This is not a room somewhere. This is a governance space that becomes available. You gave the timeline, by 39 or 41, if you talk trials or actual data. That is an element to be recognized. We're talking multiple administrative periods in the future. We're talking companies can plan their entire funding cycle. They can raise money for this. So there's so much potential there that certainly exceeds the current state of differentiation. Now, as a practical element there, everyone is looking, of course, at Europe right now. So the US right now is a more fragmented framework of regulation, mostly at the individual state level. Whereas in Europe, there's a GDPR governance structure, an AI Act that needs to be implemented, and on top of that now, the European Health Data Space. So in a way, the anticipatory or legislative drive is much, much higher in Europe. So that as a force, also at the market, needs to be recognized.
And do you think, as a, wearing your kind of commercial hat in the US, do you see this as something that can open up the European market, that kind of could make, I guess I'm just thinking, particularly with the, the challenges and the changes that are happening at the moment in the US, how do you think this positions Europe going forward? Does it lift up the priority of the European market in terms of tools? Or are you seeing this more as like it's an opportunity to use the European health data space for developing products for global use? I just wondered the balance of those two in your mind.
Sure. I think the easier answer to this is on the scientific side. It will certainly open up a possibility for scientific collaboration at a much, much different scale. So for researchers in Europe, that implies if you can get access to EHDS, you become a more interesting partner, a different collaborator with different potential behind you. On the political side, I will not go into very much detail because that will change by the time that EHDS is established. But I think the political components to it usually are overburdened by the economic impact. So, as long as we're talking about, short-sighted elements, we can't go to the prospective potential.
Thank you so much.
Can I come in on that? I think just to make it a bit more
real,
exciting in terms of the panel, having a bit of controversy. I think you're absolutely right, Joe, in what you're saying. I think the opportunity, let's talk about business, because too often we speak about European health data spaces like a big library, and everyone says, we're putting all the books in this library, and that's exciting. Well, that's exciting if you're a librarian, but if you really want to affect transformational change in society, then we just need to think about the data as the fuel that powers tools and innovation that actually transforms things. Right? So we should think about building health factories and not health libraries when we're talking in that space. And I just want to remind the audience, I think many of you are aware of that already given the venue, the incredible challenge that you face if you want to build these type of technologies with data in trade blocks, be that in the Chinese trade bloc or in the US trade bloc, where you have very little primary care data. You have mainly amazing secondary care data in the US, if you're in the right hospital, so to speak, and then you can drill down on individual patients. But the scale of the data is missing. And crucially, in Europe, but also in other parts of the world, we have effectively public healthcare systems that provide care cradle to grave, that generate data cradle to grave. And that allows you to also systematically start thinking about tools that are not just for care in the hospital, but are primary and pre-primary care. Because ultimately, in the European socioeconomic model of health, we are in theory able to shift the focus from patients that get sick and generate revenue by being sick and being treated to managing healthcare systems and health at a different level. And that's an incredible competitive advantage. And if you talk to some of the CMOs of the largest healthcare systems in the US, they will tell you, Aldo, we would love to build good cancer AIs, but some of our patients get so sick, they lose their job, they lose their health insurance, and aside from the human tragedy, we don't know if they survive the cancer or not. You can't build an AI if you don't have that data. And that's a unique opportunity that we have in Europe with the European health data spaces to use the way we run the healthcare system as a strategic advantage to build innovation in AI and health at the top of the level. And so we shouldn't be closed about this. We should be open and invite people to join, but we should also use that as a leverage to make other follows our rules around privacy, around human rights, around how we want this data used for the public and for the patient.
I would also like to pick up what you said about that our drive in Europe is to regulate. I hope it is not, because if we will only focus on how to regulate, we will never be able to implement. And that then kills all good initiatives. I think 41 Now we are planning on how to regulate something that will happen in 41. The world is not the same in 2041. I think that we have to be adjustable and agile to be able to respond to the needs and requirements. If that will be true, that in the EHDS, the company can ask, or the researcher can ask for health data from the hospital, and then we have 6 months to respond. I think that it's so slow. It just doesn't work like this. Something has to be done in order to facilitate it faster and more effective. And I think that the fact that we would, within this EHDS, would better structure the data, would ensure interoperability, that would really, and we have this kind of legal framework that would support it, not really prevent from doing it, but will support it, then I think that we would succeed, but not over-regulate.
I think to bring the 2 points together, the EHDS is enabling us right now to really delineate the digital determinants of health. This includes smart clothes, neural devices, all our cell phones, smartphones, all the elements that can track elements that have traditionally not been part of what the physician can get access to. So if you share your data with some tech giant, you will get inputs on your step length difference, your caloric burn, and all the determinants that are traditionally not available in a hospital. But very soon, if we make use of the established framework EHDS, those digital determinants of health will supplement all the others, like you mentioned, jobs, right, or social determinants of health. So that potential, in my opinion, should be regulated.
As long as it will not require more time.
But I think the kind of magic here that you're talking about is this ability to bring together health data on a kind of national scale, which is shared with health services, right? Bring together the wearables and almost the data that would be essential in prevention or lifestyle, right? Which we currently share with our tech providers. And maybe the last one I'll add in is, and the administrative data, right? Like, to Aldo's point, like, are these people still in work? Are these people in education? What was the impact of the health shock on the person's, or vice versa, the kind of socioeconomic predictors of health? What's the interplay there? Which, when you look at many of the other data sets, there's quite a division between kind of biological or healthcare data, so it's super exciting. I'm going to give the audience a heads up that we're going to come to you in 20 minutes to ask questions. So please, I'm sure you're going to have lots of questions for the panel, and we will have a roving mic. So I'm going to see if I can do a quick follow-up with our panelists on a few of the issues that have come, but please do be preparing your questions. Terry, I've got 2 questions I'd love to ask you, and I'm not sure how you're going to weave these together, but you promised to give us a kind of like, from the provider perspective, what are the potential challenges? But I'd also love to ask, given your time spent at the European Commission, what do you see the role of this project as within the wider perspective of the European Commission? Do you see this as a kind of sentinel project? Is it something that can be taken forward? Or is this really completely different to other work of the Commission?
Well, if I start from the second question, then I would say that the member states could take the leadership in it, but like the Beacon Group, those who are interested, they will join the forces and they will go for it. And if we think about the eHealth Task Force report of 2012, that's exactly what they recommended, because they thought that if we wait in a European manner until everybody is on board, then we will not succeed. Now we have a regulation, so member states have an obligation to succeed, which is good. And I think that in these terms, the orchestration from top down is perhaps more effective. However, now we come to the challenges, because sometimes I have felt that at this European level, that all seems fine. It's good values, good objectives. It all fits to the basic treaty principles. And then there are hospitals who have to implement it. And there is a gap between these two. Somehow we are required to deliver, but we are not provided with the means for it. It's not cheap. I would say that the most important is that who pays for it? We have to adjust our electronic health record. Yes, we have to do it anyway because our electronic health record in my hospital is from the last century. So it doesn't work. It was, as all EHRs, meant for reporting to the insurance. So it is basically reporting to the insurance to pay. But for the use for secondary or primary use, that's not enough. That's not all this information in the way it should be presented in order to support primary or secondary use. So that's for sure. And I have to add here that keeping in mind these type of principles as personalized healthcare and value-based healthcare, they all need a lot of more different types of data and the structured way of approach in order to provide for these. So if we have to think of changing the EHR at the hospital level, it's millions. And now I remember at the eHealth network, the chair at that time said that, well, we are talking about this type of high-performance computing, but in principle, in Austria, we need to replace the computers of GPs because they are like 286 DOS.
Yeah.
So if we think of that level, that Europe, and how different we are. In Estonia, we have the health information system nationwide. So we have easy to jump further. But there are some people who don't have even the computer that would meet the criteria of the 21st century. Then we really have to catch up with the means. And that means basically we need financial support for doing it.
It's fantastic.
Yeah. That's the main challenge. All the rest of the next round, next challenges.
I can see you itching to come in.
Yes, just to agree totally with this, of course, and funding is, of course, a very big challenge. Unfortunately, the European Commission couldn't attend, but we're really hoping for fundings at European Commission level, and maybe with their very new strategy on apply AI, where health is in a good position. And of course, for each one of the 27 member states, the funding question is really major. Thank you for raising this topic.
Aldo, I can see you're itching to come in. I'm going to let you. I'm also going to ask you another question.
Maybe it's the same.
Okay, let's see.
So I think, of course, we need to pay for it. We need to get there. We're in a pain point in terms of public funding and resources. I just want to offer the other view, the investment view, the return on investment view. And this is not a published study. I've spoken to some health economists. I hope tomorrow evening to speak to some more about actually getting the value of the data if we can systematically turn that into tools and technology. And so we've done a calculation a few years ago for the UK. What if you take all of the UK's 65 million patients' data? And it turns out that if you use existing AI technologies based on our estimate, you can effectively cover 5 to 10% of the annual operating costs of the NHS if you're able to turn that technology into intellectual property that you can then sell abroad and, say, use at cost internally. So if you apply that and you think about the scale of the European data that will be unrivaled in the world, about the type of technologies you could do, if you look at the capital expenditure you see with AI companies happening around the Silicon Valley area, you can basically get a sense that when I say, and this is my belief, I don't have proof for it yet, that the value of the European digital health innovation economy could become as big as pharmaceuticals for Europe is at the moment. And once you have that at scale, I think a lot of the numbers we're talking to, putting down a few billion to update all the GPs, pales with the $1 trillion level of revenue you can get from something like that if you're the world leading trade bloc developing these technologies.
I love this idea, and it fits very well with the question I was going to ask you, which is perhaps framed in a slightly more negative way, which is like, if this were to be true, and I love it, I hope it is true, whose responsibility is it to develop those tools? Is it the private sector? Is this a commercial agency? Is this universities with spin-outs? And for this to be true, do you feel that in Europe we have this kind of US Silicon Valley approach now, or it's something we need to change? I guess to some extent what I'm seeing is it certainly doesn't feel like, at least in the UK, that it would be the public sector. If it were to be researchers, we would have to stop finishing every research article with like, and we need more data too, right? We're going to have all the data, we just need to get going with it. So a kind of almost like a question or a challenge back to you. Do you feel, what would need to be true for this vision to become reality?
So on the innovation of startups, we should talk to Joe, because he's co-running one. But I think in terms of who's responsible for that, I think first of all, we need to appreciate that healthcare data, like all data, is going to become critical infrastructure of a country, right? If you look at the example of Ukraine, you see suddenly how important it is that you have sovereign control over your data and the means to operate in that space. And we can then talk about sovereignty, about the tools you're using, that you have governance over these. So I think that's a discussion that's going to happen simply because of the developments at the global scale. Now, thinking about innovation in that space, I think we need to make sure that the European health data spaces are not just for the big, I don't know, university hospitals of this world, just the big pharma companies of this world. I think there need to be multiple pathways, just like we shouldn't have just the EHDS is the only monolithic way of working with this data. And I hope there's going to be still a competition within each country and across countries within the EU to provide even better alternative pathways to work with the data, so we can have a competition of models that allows us to grow the economy in that space. But I think everyone is asked, and just like we have seen in the Silicon Valley space, it's not always the big companies, the big blue companies that lead the innovation of the next generation. And we need to allow innovation to happen wherever it happens with the most facility possible.
I love it. So Joe, then let's come to you. What, from your perspective, working both in the kind of academic and in the startup space, do you think that the conditions exist within Europe to take advantage of the opportunities of the European health data space and developing these kind of tools, products, policy?
Absolutely. Like you have mentioned, we have a framework now. Now it's up to the countries and the individual researchers to make use of it, push the boundaries, provide additional scientific evidence to update regulations to make it really work. Because just receiving it top down might not be sufficient. I'm pretty sure that is never sufficient. So that's a concrete task, right? What works and what doesn't work. So we can't expect, the blueprint to be rolled out, to us on the lab bench to say, this is what you have to do. That I would call it static approach has to be abandoned. The second component I want to emphasize, we mentioned out of the tech giants. Currently, most laboratories and commercial, let's call it developers or sponsors of these studies, think about obtaining the data themselves. They have their own test data, their training data, they tune it, and then they have an independent validation data set that they also acquire, typically in the same way. If they call that out of domain or they go to another hospital or multi-center study, that already is regulatory grade. What I think the EHDS offers is something entirely different. And to use the abandonment of the static approach again, you could deploy a model in the EHDS as, let's call it, a research tool, and then implement at the same time, even for rare diseases across border, monitoring mechanisms to assess the performance without ever going live clinically. And then once the monitoring and the continuous learning applications reach a certain level, then you might pass the regulatory performance requirements and you can go live, but you continue monitoring. So this is an entirely different market. The market that the EHDS will enable is one of continuous improvements that currently only the real big tech giants have, or smaller laboratories do it in static or milestone approaches. So I think both of these factors, researchers driving better regulation and a continuous, more life cycle management is certainly something that the EHDS enables, and there is no equivalent on the US side for that right now.
Thank you, Joe. And Emily, I wondered if I could come back to you and ask you about privacy, which I'm sure is a topic that came through the panel that you'd assembled. So the kind of opportunities here for the reuse and the secondary reuse of health data are unbelievable. How have you kind of built this within the French system to ensure that we are balancing people's requirements for privacy and the opportunities?
Thank you for the question. We already talked about opt-out and about data saves lives. So, of course, it can appear quite complicated to combine that data saves lives and the right to privacy for people. But as you may know, EHDS regulation provides an opt-out right for each European citizens just to refuse their data to be reused for secondary use, whatever the purpose of the secondary use. The regulation also leaves some margin of maneuver to the member states, for example, to say for some purposes and, for example, some public purposes, some member states could say, well, in some cases there is no opt-out right because we need all the sample of the population, for example, just to be accurate, for example, to struggle pandemic or so. So in France, we are very it's a very important topic, privacy. As you may know, we have quite a singular mechanism that the French Data Protection Authority is at the moment the organism in charge of delivering the data permits for secondary use, which is quite singular at the European level. So we are trying to see how we maintain or adjust or adapt this mechanism, for example. But we are very, we think very deeply that it's about privacy, of course, but also about security of data, about sovereignty of data. And this is really important in France at the moment for each stakeholder, not only for the citizens or the patients, but also for the businesses, for example. And it's important to have some requirements about privacy, but also security of data, maybe some localization of the data, which is a condition provided in the regulation. And so these are really important. And fortunately, the EHDS regulation opens to foreign and to data flow to third countries, but it also asks from requirements before allowing such data flows. And this is really, really important for French people, at least.
That's fascinating. And when you talk about the security of data within the commercial space, are you thinking to some extent about trial data from pharmaceutical companies? Like, can you give us an example of that kind of data where the security, individual security is paramount, but what are other stakeholders thinking?
When it's about security of data, it's, for example, being able to get back the data very safely, for example. It's to be sure the data the integrity of the data is preserved. So this is all these topics. And for example, when you're too much involved with a foreign provider, it's sometimes complicated to be sure that you can, for example, get back your data safely. This is one of the examples that we are really working on at the moment in France.
Super clear. Okay, I'm going to ask Elizabeth a final question before I come to the audience for questions. Elizabeth, I wondered whether in the work that you had done, you had been able to understand public sentiment about the balance between primary and secondary use. So how how much do you think that citizens or patients feel excited about the prospect of research or development of new tools? Do they see challenges in that? And how much is the benefit really focused on the kind of point of care? I can get a prescription while I'm on holiday. Other physicians will know my allergies.
So there are two different aspects here, I think. On the primary use of the data, it's quite clear. It's clear, and the patients are quite content in sharing the data. When it comes to the secondary use, they ask all those questions like why, what, and how. And it's about the communication. It's really to be able, again, to build that trust and explain and report and make the stakeholders accountable so that they can report back how the data has been used, how it is making an impact. So if they see it, if they understand it, they will be happy to share. We also see there is a difference between generations. So the newer generation, the younger people, might be more inclined to share data than the senior people. And what we need to educate them, we need to work with them to understand that. And it needs to be done throughout the hospitals with the healthcare professionals to also engage in the discussions of what it is that we are collecting and how it is used. So everyone needs to be involved in a way that the message doesn't come. We are not sufficient as patient organizations or patients to do the education of all the patients, citizens in every country. So it needs to be done by the member states that needs to be involved in that education. Digital skills is something, we see the gap. There are vulnerable people, vulnerable population in all the countries, and there is a gap between, even within a country, for those who understand what we're talking when we are talking about data, or even just, so the European health data space is completely new for them. As you were saying, there's zero education on this. So what are you talking about? What do you mean someone else will have access to my data? I need to understand. I love the vision that you have. But for me, from the patient perspective, I can see already all the voices in my head saying, nope, that's not going to work for us. What do you mean? We need to explain that, and we need to accompany people in this. Because as you said, data saves lives, that's clear. But that clarity needs to go there to every individual people, because everyone will be at one point a patient. Everyone. So it's not a question of when, it's everyone will become, and we need to make sure that they understand that. So I think the accompanying, safeguarding, making sure everyone is accountable for what they are doing with the data and can report back that there is a tracking process at member states level, not just at European level. And this is a huge, huge challenge. Interoperability is already a challenge. When we see data collection across countries, it's so much work. But I see that by working together, little by little, step by step, and making sure that if we want the patients to buy out, we have to work with them at the initial stage. Right now, start educating, start involving them in the discussion.
Thank you so much, Elizabeth. What a great message. Right. Let's come to the audience. We would love to hear your questions. We would love to hear any comments. And we would love to hear your interventions. Gentleman here in the second row, first to put his hand up.
Thank you very much. Pedro Barata from the European Medical Students Association. So this is quite the ambitious project, and one of the priorities in that, and as it should be, to have a user-friendly platform, not only to the new physicians and to the old ones, but also to the tools that we have available. So my question is, how do we make this platform so that patient care and patient privacy is not harmed by digital illiteracy from our physicians, and also from the tools that they have available? Thank you.
Thierry, do you want to come in? It's such a great question. I remember graduating from medical school and going to my first clinical assignment, and the professor I worked with typed like this, right? And I think my mind was blown. And of course, the poor guy spent like 40 years working, and then somebody's implemented an electronic health record system. It's just think, what a nightmare.
Well, if you have started like this, you will not learn like this. That's for sure. But that's why we, for example, could use the speech recognition system, that you don't have to type at all, but you have the system that will recognize what you are saying. And not only write it down, but also put into the light boxes. the right information in the right place. So that's possible. That's already possible. So that is what I would say, that if you want to implement something efficient, you have to start from fixing first things first, so that the basement is right, the system is reliable and trustworthy. In our system in Estonia, we have the logbook. So whoever looks at my data has to log in and identify themselves. So patients can go and see who has looked at their data. So that is creating the trust, the system. I can always ask why these people looked at my data, what they have to do with my disease. And if they had no reason for doing it, they can be interviewed.
That's a euphemism for...
Yeah. But that is something what I really want to say, is that instead of creating something huge, acquiring high-performance computing, for example, but your home level is a mess. You can't reach these objectives. I think it's all fantastic that you said, Aldo, really. I like it also. I am a big dreamer. And I dream big, because then at least I achieve something small. But I think that it has to be started for fixing simple things. Let's make the electronic health record structured, standardized, and interoperable. That's the first thing. If you need for it the computer, fund the computers, fund the systems, teach people, that invest into this, so that if you start the first things correct, then you can start building on it.
So invest in the foundation.
Exactly.
Give the support to the genius professor who's been asked suddenly.
The genius professor will just use next time speed recognition. But I remember it so well how it happened in Greece. I don't know when any doctor from Greece is here, but I remember how the electronic prescription didn't work there. And not because it was electronic or whatever, but because of the keyboard.
Aldo?
So I like what you say. If you do things, then do them properly. That's what my mother told me. And that's great. I think the problem is that we shouldn't end up in a paralysis of innovating and moving ahead by making sure that everything is perfectly dotted the T's, dash the I's in terms of how we do things. Because I'll give you an example. So in the British secure data environments are some as old as 2009. So it's really cradle to grave data there. They're not aligned. They're not using SNOMED CT because they use older read codes, for example, right? And so there's a mess around that. And look at that. AI digital health research groups can build and develop adapters that curate the data for you autonomously. So yes, we should plan things properly, but things change anyway. So let's not wait for everything to be perfect before we start taking the next step. I think we should start walking towards a direction that is the right direction. Then we can work out the details of the route.
But you have to make the first step.
Yes. And so the real first step is, again, thinking about moving from a librarian mindset to the factory mindset is we have now health data spaces. All the health data will be in a secure data environment. You cannot export the data. It sits there. You need to log in there and do your compute. Then you have the next problem. Now you want to build a big AI model. Well, you need a lot of compute for that. That compute, the European Union is investing in these major AI factories. We're talking billion-dollar level investments. Nothing compared to what US private industry has, but still at scale. Now, how do we link that compute that doesn't sit in the secure data environment with our healthcare secure data environments? That's a problem that some of us are thinking about, but that's the next step. And the next step is, again, if you think about digital healthcare algorithms like pharmaceuticals. Say, if I have an algorithm that predicts or prevents you from having a stroke because I get to see a neurologist in time, then that's like a vaccine. It prevents you from getting sick from stroke. And now we talk about digital vaccines. Now, if you think about that, in pharma, we have, as a gold standard, international multi-center trials of treatments. And they're expensive to set up and complicated. In the right way, thinking about routine health data spaces, you can think about a test bed for digital health where I come with my algorithm, press a button, it runs in 20 healthcare systems in parallel on their data, and I have an immediate evaluation of how portable my algorithm is and how useful it is. And just remember, 95% of all digital healthcare algorithms as published have not been trained on new clinical data. The 5% that have, again, 90% have only been applied in a single institution or hospital. And major successes or heralded public successes of AI for health have failed because they don't port. So we need an infrastructure that allows us to rapidly evaluate, test, and validate, and ultimately certify at a European level of quality the technology that we're developing.
That's so clear. Thanks, Aldo. And I guess maybe just to what I hear as well in what you're saying is you're pushing us to think, what's the use case? What's the impact? What's the change we need to see? And therefore, what's almost the requirements for this? Joe, I can see you itching to come in, and then we're going to go to the audience and take another question.
It sounded like you wanted something very concrete. And I don't know if that's applicable or so, but I think right now it's all in the operations. I think, Amazon has disrupted so much by streamlining logistics. And the biggest problem in medicine right now is access and coordination and the real mundane stuff. Calling someone, not being able to reach a practice, not being able to schedule an X-ray, not getting access to an MRI, has nothing to do with the machine or the AI tool running the imaging algorithm. It is the gluing all the pieces together. So I would say that, as a concrete thing right now, bound by the EHDS, that would be something to strive for.
Super exciting. A lady here in the front row, blue trousers.
Thank you very much. Sure. Thank you. My name is Felicitas Mood. I'm a scientific advisor in digital health, and I think we can't stress enough how the EHDS is going to give us data sovereignty in Europe, which is very important. But at the same time, I'm wondering, how do we ensure that there is good quality data going in, meaning it's representative, and especially we won't have structural biases due to several opt-outs?
Aldo, you itching to?
I have a very simple answer for that. We need to think about dealing with biases and be awareness of that. And of course, in Germany, you have the problem that you're not even collecting ethnic or racial data because of German history, but that's a separate discussion. But I think the key thing is start using the data. Don't build tools in 2029 after you've spent 5 years collecting the tools. You will see if you fail building tools today, what is missing or not working with that data. So don't will till the end, just get going. You will face loads of problems anyway, but at least you're solving problems that are useful to solve.
And I can say that not many people opt out. Actually, quite few people opt out. They have this opportunity also in Estonia, but it very rarely happens.
Yes, I fully agree with what just has been said, and it's important just to start, and we will see if we have some opt-outs. The data sets will provide this information, so the searcher will have the information of the average of opt-outs, for example. So I don't see it as a real obstacle, nor as a bias, because it's true. We know at the very end of the day, very few people opt out in reality.
So the message is, let's get going and work out how much of an issue it is and therefore what the bias is. I'm going to come behind me. Yeah, gentleman here in the front row. Sorry to the lady with the microphone running over.
Yes, thanks a lot. Julius Moka, I work for the German Development Corporation in Cameroon. And it's a really, really exciting discussion. And I think for us in actually working in Africa, it's as well an exciting discussion because we discuss the same things. And you were talking about dreaming big. And I wonder if we say EHDS is as well like this factory, right, for tech. But we actually compete with global tech giants that have access to global data sets. Should we not say, hey, there are low-hanging fruits in doing certain things together with our partners beyond Europe so that we can say we as well build technology actually in global data sets and not just EHDS? So my question is maybe a little to Joe. For you, kind of from private sector, what do you see kind of as a return on investment to say, let's think this thing a little bigger?
it's always good to dream bigger, but at the same time, harnessing the value as early as possible is, in my opinion, a strategy that has had incredible commercial success. If I may, I have nothing to do with it, and I don't own stock, so there's no conflict, but the Apple iWatch as a healthcare device has proven to be a quite successful tool with incredible additional non-regulated aspects that now successively were introduced. That was harnessing global data that was, of course, introduced through an FDA approval first for AFib, and now for additional successive elements. Now, reflecting that back onto the EHDS, that's certainly possible. Having access to multiple data from multiple countries is creating, I would say, a market. Now, whether that requires immediately to jumping to, let's say, a global solution, I highly doubt. It's possible, but it requires still tremendous resources. The second aspect on, I think you mentioned Africa as a different continent or a different market. I think the underlying data, however and wherever they're collected, hold a separate value for separate markets. And that needs to be recognized. So while a global strategy might look impressive, it can be completely opposite to a very successful local solution that can create enormous revenue in that realm. So the denominator of that market, let's call it, or commercial strategy is very important to take into account. It's not just the absolute sum of net revenue, but the net revenue created through a denominator of the, let's say, target population or persona that you do marketing to. So I would not say one or the other. It depends totally on the style or the creation of the business or revenue proposition that you have.
Thank you so much. Aldo?
So one thing I want to add from a development perspective, I think that's really important, is that everything about the ideas, yes, we write Europe on it and it's the European Union and so forth, but I think a lot of the ideas behind that, there's nothing that is not implementable across the globe in different countries. So thanks to the Gates Foundation, I'm involved in the Ethiopian efforts in that space. And, if you have the political will to be data-fine, data-driven and transform your healthcare system accordingly, you can, right? And I hope that Europe will stretch out a hand and say, why don't you join this effort? We're happy to share knowledge and know-how to really spread that. And we're seeing that. We've advised Malaysia on this, and we're seeing also other countries becoming interested in how to think about digital health with your sovereign data, because ultimately you need to help your population, and that you do best with your data, right? But then it helps to have some additional data. But this approach idea that I think the European Union is pioneering here is what is, to speak, the core intellectual component to that. And then a lot of other technologies will become portable.
If I may add here also one point that I learned as regards the implementing telemedicine. Actually, Europe learned from the good results of using telemedicine from Africa, because the first project was in Senegal, where we learned that, that's quite effective on a distance. And what we in this cooperation, and it was together with the WHO and the International Telecommunication Union, what was very clear was that this regulatory framework has to be in place in order to not allow so that a company may use an opportunity that there is no regulatory requirements and will implement something which then will be like a vendor lock at the later stage. So that like this type of state requirements have to be in place. I think that Europe could also be in a good learning place from what that not always so much has to be done. But some basic legal frameworks have to be in place to avoid this type of abuse of the system later.
It's so important. We're going to take one more question here from the third row.
Thank you. Thank you very much. Alberto Borrego from NTT Group, Japanese organization. I think the EHDS regulation is a huge step ahead, but I would like to ask you, any of you, if you think that, bearing in mind that 95% of the technology, AI technology and cloud technology is not in the hands of European organizations, sovereignty can be kept in the long term. Thank you.
Could you repeat the last bit? 95%, is it not in the hands of the European Union?
Or it is not in the hands of European organizations.
Yeah.
I mean, European companies. It's in the hands of the hyperscalers. Is it possible to keep European sovereignty on health data in the long term? Thank you.
Thank you so much. Okay, let's do Emily and then Aldo.
Yes. Thank you for the question. Of course, it's a tricky one. It is not because it's a complicated issue or a challenge that we don't have to deal with it. So, of course, it's really complicated, you're right, but we think we can find some ways, some requirements, some specific European requirements to try to find some ways, maybe in some cases just to be conscious that we are under a domination from foreign actors. This could be a way, but just to have it in a clear conscience, for example, for certain hospitals, in some cases, it's already the case in some European countries. That's why, for example, in France, at our very small level, we try to foster transparency, at least, of what are the dependencies of the provider and other subsequent providers to foreign legal systems, for example. So that could be a first step, but of course, European sovereignty doesn't mean, or not very simply at least, doesn't mean cutting off from any other interdependency with foreign actors or hyperscalers. This is not the aim, but the aim is to try to find a way to have some basic requirements, maybe, and it's if we try to find them at European level, it's sometimes quite difficult, to be really honest. But maybe EHDS regulation is a little start, because there are some sovereignty requirements in it. It's the first time, so it's maybe the first step.
So, sovereign AI and sovereign digital health is something I'm very passionate about. And, we've presented last year, or this year in Davos, a white paper on that, and we're presenting again in Davos this year, something on that. You can find it all on sovereign-ai.org. I think what I meant earlier is healthcare data, like a lot of other data elements, are becoming critically realized to be critical infrastructure. So I was delighted that 2 weeks ago we had a meeting of military and healthcare people from across different countries, including Ukrainian colleagues, so that we could exchange ourselves about what the best steps are to render us more robust. I think when we're talking about sovereignty in the digital space, it's not about having your own private complete technology stack. I think only China can afford to do that, and the US can afford to do that. I think it's about having clear establishments and trade-offs of risk versus critical dependency that you need to think about what you want to have, where you want to be coercible, be that for tariff or economic negotiations or military and gray zone conflict. But I think a key additional element is the sovereignty over the data becomes important, and I think we struck that. That's a resource. But similarly, the sovereignty over the compute, so the governance over the compute, the model, the operational, and the legal in traceability and accountability are effectively six-dimensional space you need to map out when you make decisions about what you actually need sovereignty for and what not. And you can find a model of composition, just like if you look in the military space, you will have major defense companies that are part-owned by families of governments from other countries. So we have a way to deal with that. And surprisingly, the military space, and we're maybe not so comfortable in the health space to talk about that, has some valuable lessons that we can port over into the healthcare space or general public sector space sovereignty.
Thank you so much. So we're going to take a question here on the front row, and then see if we can get two more. Yeah,
Hello, my name is Yifan. I'm from International Pharmaceutical Students Federation. I was wondering if there's an ethical framework surrounding dealing with children and youth data, and if not, what should go in there? Thank you.
Emily, do you have any thoughts on an ethical framework surrounding children and youth data? Or Elizabeth? Are there any specific considerations for children within this space?
No, no specifically, no. No, it's in the EHDS regulation, every health data is treated like health data, whether it concerns adults or children. There are no specific, there are only one provision about EHR systems that provide that the children can be involved in his accessing his data in his own EHR system, and this is mandatory for each member state. But there is no other specific regulation, at least in this regulation, concerning children.
Although you're itching to.
Yeah, I wanted to expand your question. So there's birth, and at the other end of life, childhood, right? And the other end of life is death. And most people will be surprised what happens with the data once they die, because all your data protection ends once you're dead. And I think that's a challenge that we need to think about, because people will want to know what happens there.
Thanks for the volley. One area that is extremely interesting, which is currently in big discussion in the EU as well as in the US, is neural data. So specifically brain-computer interfaces. You know, for those who don't know, it's typically a chip or a recording device on the brain surface that can trigger a computer with a customized AI tool specifically trained for that given patient to take on executive functions. For example, writing with thought, which would be even faster than speech to text. You know, these technologies can move robotic arms, etc. This is not science fiction. This is existing for the last decade. But right now, the legislators across the planet consider how to regulate thoughts. This sounds a bit like, you know, an Asimov comic or something. But in reality, this is currently being actively discussed. And to come back to Aldo's point is what happens when you have such a model that has been used by a patient, let's say with a neurodegenerative disease, for many years, and the patient dies. This model takes the abstraction of all these executive functions and holds tremendous value. And if you extrapolate that over a larger scale population or over many, let's call it post-mortem data sets, you know, for me as a pathologist, I truly know the value of post-mortems. And for those who use that term in project management, you know, when a project goes wrong and you do a post-mortem, you learn a lot. So in other words, the data that suddenly becomes publicly available, you know, in the US, everyone is worried about, you know, identity theft. But when you die, your social security number is publicly available. You can Google it. So what I think is required is also to expand, especially when it comes to neural data, but also in the EHDS, to consider these edges of life and these specific use cases. For example, data in utero, you know, who's responsible and accountable for that, but then also post-mortem data, because the data continues the value beyond the life expectancy of the individual that they derive from.
It's fascinating. All right, panel, I'm going to try and take two final questions. Gentleman in the blue shirt and the lady in the white shirt, please.
Good afternoon. My name is Wing-Yin Chan, and I'm starting to work for a new non-profit startup with a digital platform in Germany, starting in Germany. In considering on this, the setup or the work, the design of this system, one of the major point is how can we get the clinicians to involve, simply buy-in argument. Most of the system, the doctors are working at limits. And and they are not quite keen on coding, working with new system. If you're asking sacrifice, how are you compensate them for working new things, maybe taking up higher workload? Well, if you start up with a new data space, asking for sacrifice, without compensating them with really use cases that increase their productivity. We're in a conflict situation. Yeah.
It's such a great question, Thierry. Let me ask you.
That is quite around the question beyond, is between library and factory.
Yeah.
Well,
I am not actually fully 100% supporting your idea of library, because if I think of what ChatGPT does, that is all based on library. So I think that it's not factory. It's kind of analyzing all information available. Library is not the books. Library is information. But that was not your question. What I wanted to say is that most difficult in the hospital is to sell to medical staff something that requires time. If it is extra time, they don't like it, even if you say that they will have better results. If you say that this saves time, then it may work. So additional tasks have to replace something else, or that you can automatically do something that you did before by hand. And then that would be the benefit. I think that the digital tools in general have to either save time, money, or bring better results. But time nowadays comes first.
It's fantastic.
But most of the usage of this digital space will be in the ambulatory business. Yeah. And most of them are entrepreneurs. Yeah, so they will ask, how much do I earn more? Okay, not just productivities. If you are employees in a hospital, yes, yeah, you get bonus. But for the doctors in the private care, in the ambulatory, they want to ask a question, how much I would earn more? Or let's say, how much leisure time I will get out of this new system.
Yeah, that you have to demonstrate.
We're going to take one last question. I think your question about the incentives and the kind of misalignment of the incentives is one definitely to follow up in the coffee break. Last question.
Thank you. Catarina Cardoso, Portuguese Medical Students Association. And I wanted to bring up a question regarding the ethical considerations. We've talked a lot about how important and how valuable this data integration is, especially when you touched upon maybe connecting also private sector data with these public data that we're getting from the healthcare sector. And Elizabeth touched a bit about we have to involve different stakeholders in ensuring that patients are informed and that informed consent is actually informed. But how effectively will we get there, and how effectively are patients making sure that they're consenting to something right now that in 6 months, with the pace of the AI, is very possible, will be completely different, and this data is already being used in a completely different manner. So I would really like the input both from the patient side, but also from the government side, or how can we effectively control that? Thank you.
Elizabeth? Thank you for the question. I think for the ethical, it's a very broad topic and matter for the patients to see that indeed they are considered at the very beginning, and I think the first advice or recommendation is listen to the patient first, understand their needs, and then build on it. And the ethical framework needs to start with that. And obviously there are all the legal requirements that will need to be taken into consideration. But the ethical bit starts with being inclusive, being patient-centric, and making sure that we respect through time the wish of the patients. So the right to opt out is very crucial. Depending now, this discussion really opened more questions and more work that we will need to do. Discussion we will need to have with the patients, like what the right to deal with your data after your death. That's something that we haven't touched upon, but that's really important. But those are the discussions that we need to have on a continuous basis with the people, so that they know what they are signing up for. So that's where I think it's very important that there is an open forum for a continuous dialogue between the patients and the people that are contributing the data and the other stakeholders that are going to build this framework.
It's such a fantastic, we're so pressed for time. So what I'm going to do is I'm going to ask the panel one last question, and then I'm going to invite the audience to basically surround them as we leave the stage and ask any final questions. They can't escape. So panel, just one very final. I kind of opened the discussion with talking about what happened 5 years ago in a very different world, mid-pandemic, when this was really just an idea. I would love you all to look forward 5 years and tell me, what do you hope is true? What are we sitting here in 5 years? Maybe it's not us, maybe it's the next guys who are looking at this European health data space, and we say, it's a success because. And if you could tell me just one line, what do you really hope that this is going to deliver? Joe? Oh, sorry.
No, I just wanted to say that if there is a will, there is a way.
Okay.
Well, in 5 years, I hope that we have made use of the EHDS and that there's a commitment to those shared values underlying the proposal.
I love it.
We will be very happy if there is effective, for example, use case, including cross-border data sets, reuse for research, for rare disease, for example. So this is for one example. If I have to choose one example, maybe it's the rare disease and the multi-member states data sets use case. Concretely.
Thank you.
Succeed.
Elizabeth.
It would be a success for us. So if we see that in all the processes, the patients are being involved meaningfully, and that indeed there is an educational program, digital and health literacy program that accompanies the framework to be implemented in a way that is for patients, with the patients.
Thank you. Aldo?
My wish is that in 5 to 7 years, we'll see the benefits of digital health at the primary, pre-primary care level to a level that citizens feel a stronger belief in their government and in their state and in democracy. And that we'll have at least 2 European digital health unicorns.
Love it.
And we have funding.
Oh, what a fantastic note to end on. So I hope you'll join us again in 5 years' time to continue the discussion. But in the meantime, please join me in thanking the panel for a really fantastic discussion. Thanks so much.